By listening to this podcast, you agree to not use this podcast as medical advice to treat any medical condition in yourself or others, including, but not limited to, patients that you are treating. Consult your own physician for any medical issues that you may be having. This entire disclaimer also applies to any guests or contributors to the podcast. Under no circumstances shall any guests or contributors to the podcast or any employees, associates, or affiliates of the Neuroendocrine Cancer Awareness Network be responsible for damages arising from use of this podcast. Welcome, everybody, to another edition of Let's Get Real with NCAN. I'm your host, Mike Wayman, and I want to thank you again for listening or watching wherever you may be consuming this. Please make sure that you like and subscribe. It helps this show a great deal when you do that, and it costs you nothing. Little house cleaning to do, a little bit of NCAN news. We have our live stream Q&A. Centered on net nutrition with Leanne Burns. She is a registered dietitian. That'll be on September 4th at 7 p.m. Eastern Time. That'll be on the NCAN YouTube page. Please come join it. You'll be able to ask your questions live, and she will answer them for you right then and there. We also have our September 28th Nashville Net Patient Conference. It's at the Cambria Nashville Airport Hotel. It'll be a great time. We have it's hosted by the University, Vanderbilt University, out there with Dr. Robert Ramirez, as well as plenty of other doctors. We also have our virtual walk coming up, so please sign up, do a little bit of walking anywhere you are. Send us pictures. We'll put them all over our social media. Tag us. Again, our social media is at NetCancerAware. And information on all these events, all these programs that we're doing, it's all in one spot at netcancerawareness.org. So today, I'm really excited to welcome back a great guest of ours that we've had in the past. Ladies and gentlemen, Dr. Shikha Jain. How are you?
I'm good. Thank you so much for having me. I love this organization, and I love talking about neuroendocrine cancer and talking about all these topics. So thanks for having me back.
No, I appreciate it. I appreciate you coming back. And today you're going to talk to us a little bit about carcinoid heart disease.
Yes, I'm going to start with a very quick, brief overview on neuroendocrine and talking about zebras, and then we'll talk about carcinoid heart disease at the end of the talk. But yes.
Awesome. So I'm going to step out here, and I'm going to give the floor to Dr. Jain.
Great. So I'm going to, like we said, we'll be talking about carcinoid heart disease, but in order to talk about carcinoid heart disease, I always like to give kind of a general overview about neuroendocrine, but I won't spend too much time on this because I know this is something you all are very well versed in. So let's talk briefly about the recent advances in neuroendocrine tumors. So if you look back in the 1980s, that's when streptozocin was first introduced, and then octreotide came out later on in the 80s. Then it was a very long dry spell until you get to the 2000s when we started seeing things like everolimus and sunitinib and PNETs, lanreotide, and then everolimus in GI and lung net tumors. And then more recently, in the last decade or two, we've started seeing things like dotatate scans leading to the ability to give lutetium and PRRT therapy, CAPTEM, and a lot of other exciting agents that have come up, telotrestat in the last 20 years or so. So I love history, so I just want to touch a little bit on the history of NETs. It was back in 1888 that it was first described as a pathological entity of carcinoid. And then in 1890 was the first description of ileal carcinoid. And then in 1907, the term carcinoid was coined, described as something that was small, multifocal, undifferentiated cellular formations with well-defined borders. At that point, they thought no metastatic potential, and they were seen as slow-growing and harmless. Now, the thing that are keys to NETs that we know now, they're epithelial neoplasms derived from neuroendocrine cells throughout the body. Most commonly, we see GI tract NETs, which is what I specialize in, then less common lungs, and then other types of NETs. They're rare by incidence, but they're definitely more common by prevalence. Most grow slowly in comparison with their adeno-CA counterparts, and the majority are sporadic, but some are associated with familial syndromes like MEN1, MEN2, VHL, and neurofibromatosis. And somatostatin receptors are typically present on cell surfaces. There are 5 somatostatin receptor subtypes, so easy, counted 1 through 5. And the interesting fact is that over 80% of these NETs overexpress number 2. So are NETs really this rare? I bring up this slide because we call it a rare tumor. It's a low incidence, but it is on the rise, and it's a higher prevalence than actually what's appreciated. So prevalence means the number of patients that are alive. It's interesting because many NET patients live for a very long time, so the prevalence is actually much higher than you would anticipate. The challenge with treating NETs often is that the nomenclature has become kind of confusing, and it's evolved over time. Back in the 80s, the WHO called it by cell of origin, so islet cell, enterochromographine, gastrin, and then unspecified. But in 2000, the WHO reclassified it by degree of differentiation, so well differentiated versus poorly differentiated. Then in 2010, it evolved into by grade, so grade 1, grade 2, and grade 3. Grade 3 being the more aggressive small cell, large cell types. And then 2019 digestive WHO classifications changed to grade and differentiation. So again, we've seen an evolution in how we've discussed and described these types of NETs. So diagnostic workup, I think this is a really important key, because when we talk about how we identify NETs and talk about the NET progression of diagnoses and tissue diagnoses and imaging, we look at imaging with cross-sectional imaging, multi-phase CT, somatostatin receptor imaging like dotatate scans, or there's a gallium dotatate that is used more often these days, and you look at FDG PET scans as well. So I want to focus for a moment on the fact that these scans are very useful if these patients have tumors that are going to be hormone producing. So, for example, the somatostatin receptor imaging can be very helpful for patients who are producing a lot of the hormone. The challenge becomes patients who have the higher grade neuroendocrine tumors, or the ones that are behaving more like small cell cancers. Those ones are more likely to show up on your traditional PET scan as opposed to a dotatate scan. We often like to get this tissue diagnosis from the primary site, or if they're metastatic, from a metastatic area. And again, we look at the WHO grade, the Ki-67 to tell how aggressive it is, the mitotic index, and the degree of differentiation. And these are just some images here of CT scans, octreotide scans, and dotatate scans, and how they display these types of presentation. So now this is where we start talking about hormone status. And this is the part that I was kind of alluding to in the last slide. There are functional tumors and there's non-functional tumors. And the functional tumors are really the ones that can cause symptoms like flushing, diarrhea. They're associated more with carcinoid. So these are usually more localized disease. They're often liver dominant, and they're often low grade and pretty well differentiated, and they grow pretty slowly. The non-functional tumors are more likely to be metastatic. They're more likely to be high volume, so more evidence of disease. They're more likely to be high grade. They're more likely to have progressive kind of growth. And often these are non-pancreatic tumors, and the SSTR status, or the somatostatin receptor status, is often negative. So again, functional tumors are more likely to show up on the dotatate scans and the gallium scans, and the non-functional tumors that don't produce the hormones are more likely to show up on your more traditional imaging, like your traditional PET scans. So hormone status, again, talking about the functional, and I want to focus on this for a few minutes because carcinoid syndrome and carcinoids often have high levels of these circulating hormones, and carcinoid syndrome can actually be a direct result of the hormones that are being released. So carcinoid syndrome, we see it in 10% of small intestine tumors, and they produce these peptides, amines like serotonin, 5-HIAA, and patients develop flushing, telangiectasias, diarrhea, bronchospasms, hypotension, and the liver inactivates so oftentimes the liver inactivates these bioactive products that are secreted into portal circulation. Thus, carcinoid syndrome is predominantly seen in those patients who have disease in the liver, because the liver is supposed to inactivate the bioactive products, but if the tumor itself is in the liver, then there's nothing to inactivate those products. Functional pancreatic nets, 40% of pancreatic nets are these functional nets. More commonly, it's the insulin type, where they produce insulinomas. Gastronomas are the next less common, then glucagonomas, and then VIPomas. And the symptoms in these particular cases are often defined by the hormone that is secreted. Non-functional, those tumors are usually the ones that patients are not symptomatic from hormone production, and the symptoms that they develop are from the cancer itself, from the tumors, not from excess production of hormones. So, well, it looks like this slide is not working out so well, but when we talk about the extent and burden of disease, we talk about the extent and burden either localized or metastatic. So there's low volume and there's high volume disease. And we have to think about, are we focused on controlling their hormone? Are we focused on controlling low volume disease? Meaning, are we trying to just deal with the hormone production from this low volume disease? Or is it somebody who has widely metastatic disease that has a higher volume of burden of disease that we need to give chemotherapy to try to control? So when we talk about staging, NETS was added to the AGCC in the 7th edition, 2010. And again, I'm not going to spend too much time on this because the staging is in all the guidelines. But the most important thing to know, again, is it uses TNM staging, and the tumor, if it's limited to the pancreas and it's less than 2 centimeters in size, it's T1. And then again, T increases based on size. Metastatic is stage 4, as with other malignancies. And again, this goes back to defining, these are well-differentiated neuroendocrine tumors. They typically do not progress and become metastatic, but when they do, the main symptoms patients typically have are from the hormones that are produced. So now let's talk about grade and differentiation, because again, that goes back to how these tumors are treated. So grade and differentiation, there's the low grade, which is well differentiated. There's a high grade, which is a poorly differentiated. And we look at the thoracic classification and the digestive classification. Again, because the thoracic nets are different than the GI nets. So thoracic nets are typically, they can be a typical carcinoid, an atypical carcinoid, or they can fall into those high-grade small cell neuroendocrine or large cell neuroendocrine groups. The digestive WHO classification, again, well-differentiated, grade 1, grade 2, grade 3. And then there's a poorly differentiated neuroendocrine carcinoma. Again, that behaves like a small cell or a large cell. These are just some pretty pictures that can show you the difference between the activity of grade 1, grade 2, and grade 3. Grade 1 typically has a lower Ki67, so you can see these images up here, less than 3%. Grade 2, you see a bit more of the Ki67, 3 to 20%, and then grade 3 is typically a Ki67 over 20%. Pace of growth, again, the good thing about the carcinoids and the lower grade, well-differentiated carcinoids and neuroendocrine tumors, they typically have a very slow progression. The higher grade and the more poorly differentiated tend to have a more rapid progression. And again, looking at primary site, there's the pancreas, there's the small intestine, and the lung, which are the non-pancreatic sites, but most often we see these in the GI tract. So neuroendocrine tumors are sometimes referred to as carcinoid tumors, especially when they affect the small bowel, the large bowel, or the appendix. Carcinoids are typically small, slow-growing neuroendocrine tumors, and many carcinoids don't produce symptoms because most of the hormones they produce are metabolized by, again, that first pass effect in the liver. But carcinoid syndrome can occur if the serotonin-producing tumor has metastasized to the liver, thus bypassing this first pass metabolism, which then results in this hormone resulting in significant symptoms for patients. Most carcinoid tumors don't cause carcinoid syndrome until they are more advanced. Carcinoid syndromes occur, like I said, when tumors metastasize to the liver, and then these vasoactive substances make their way into the bloodstream. About 5% of patients, especially those who have primary ovarian or pulmonary sites, as well as those with mid-gut carcinoids with retroperitoneal mets, may present with carcinoid syndrome without liver metastatic disease. And again, the symptoms can be episodic flushing, diarrhea, and then this right-sided valvular heart disease. So let's talk a little bit about carcinoid syndrome and what all it can cause. So we know that carcinoid syndrome can impact the heart. That is one of the most concerning aspects of carcinoid syndrome. It can impact the heart with pulmonic and tricuspid valve thickening and stenosis, can result in endocardial fibrosis. It can result in hepatomegaly, diarrhea and cramping in the GI tract, cutaneous flushing and cyanosis of the skin. You can have coughing, wheezing, dyspnea, and you can develop retroperitoneal and pelvic fibrosis as well. So let's talk about carcinoid heart disease. Carcinoid heart disease is a cardiac manifestation that occurs in patients with advanced neuroendocrine tumors and often carcinoid syndrome. And it typically involves the right side of the heart valves and eventually can lead to right-sided heart failure. So why does that happen? Well, outside of carcinoid, left-sided heart failure is the most common type of heart failure. The heart loses its ability to pump blood out to the rest of your body, and it usually is caused by coronary artery disease. However, in carcinoid heart disease, right-sided heart failure is more common, and the heart loses some of its ability to move oxygen-depleted blood to the lungs to pick up new oxygen. Outside of carcinoid disease, it's most often right-sided heart failure is caused by left-sided heart failure. But in carcinoid heart disease, it is more likely that it is directly causing the right-sided heart failure. So the incidence of carcinoid heart disease among patients with carcinoid syndrome is about 50%, and it can be the initial presentation of carcinoid syndrome in as many as about 20% of patients. Carcinoid heart disease accounts for substantial mortality and morbidity, and right-sided heart valve involvement is the most common. Again, most cases are associated with small bowel neuroendocrine neuroendocrine tumors, then lung, large bowel, pancreatic, appendiceal, and then finally ovarian neoplasms. And then there's about 20% of them that are caused by an unknown primary. How do you evaluate for this? How do you check your patients for this type of thing? Well, we often recommend checking a pro-BNP because it's really a good biomarker for screening carcinoid syndrome in patients who have evidence of clinically significant carcinoid heart disease. You can also do a 24-hour urinary 5-HIAA level. If it's greater than 300 per 24 hours, that's a useful marker for identifying those who are at risk for developing carcinoid heart disease. And the characteristic findings in people with this type of disorder: plaque-like deposits composed of smooth muscle cells, myofibroblasts, extracellular matrix, and an overlying endothelial cell, a layer which can then lead to valve dysfunction. So this was an animation that is looking like it is faulty here. But so the picture on this, the main thing for you to look at with this picture is you can see here the types of valves that are really involved. And what the graphic underneath that slide is trying to describe for you is a particular study that looked at carcinoid heart disease pathology. And what they found that was in 75 patients, 45 men and 30 women, age 26 to 78, 139 valves were excised surgically. 73 of them were tricuspid valves, 55 were pulmonary, 6 were mitral, and 5 were aortic. They found that pure regurgitation in these carcinoid heart disease patients was the most common dysfunctional state, with 80% of it being tricuspid valve, 97% being mitral valve, and 96% being the aortic valve. But the pulmonary valve was more often both stenotic and insufficient as compared to regurgitant. And in all cases, the valve dysfunction was due to carcinoid plaques. So these plaques then led to thickening and retraction. Cellular proliferation and deposition led to thickening. And then these plaques led to neovascularization, chronic inflammation, and then mast cell infiltration, which then resulted in these valves basically failing. And then you ended up with pretty significant right-sided heart failure. And so what this image is showing above the words is that you can see here the tricuspid valve, the pulmonic valve, and kind of the imagery of what these valves look like when they're so damaged by carcinoid plaques. And another animation that seems to not be working so great here, but I can share with you that TTE remains the gold standard for diagnosing and following up carcinoid heart disease. For people who have established carcinoid heart disease, an echocardiogram should be performed if dictated by a change in clinical status. Otherwise, you can do it every 3 to 6 months, depending on the severity. A cardiac MRI can be used to look at the pulmonary valve and identify cardiac mets, because that can sometimes happen where you end up with metastatic disease in the heart. And a cardiac MRI can also be used to assess right ventricular size and function. There are some long-acting formulations of somatostatin analogs that are the standard treatment to alleviate symptoms and prevent the development and or progression of carcinoid heart disease. So again, this is a situation where you need to really focus on controlling the hormones. So carcinoid heart disease is due to the fact that there are large levels of these hormones being released that's causing this problem within the valves. So you need to make sure that patients who are at risk of carcinoid heart disease have very good hormonal control. This flow sheet here is showing what you can do for patients with neuroendocrine tumors that are producing serotonin. So every 6 months, they should have a clinical assessment and they should be getting their BNP measured. If their BNP is less than 260 nanograms per milliliter, you can continue with the every 6 month surveillance. However, if their BNP is greater than 260 nanograms per milliliter, then this is likely going to be a presentation of carcinoid heart disease. In that case, you want to do an echocardiogram plus a contrast study for carcinoid heart disease and also look for a PFO. If the echocardiogram is normal, then you can refer to a cardiologist and you can also continue this every 6 month evaluation. So the pathogenesis of fibrosis in carcinoid heart disease is really poorly understood. It's thought to be from the effects of neuropeptides like serotonin and growth factors into the bloodstream. But the thought is that this chronic exposure to excessive circulating serotonin is one of the most important contributing factors. And the endocardial fibrosis that especially impacts the right side of the heart then results in this tricuspid insufficiency and or pulmonary stenosis. And you can see here, this is just an example of how the hormones that are being produced actually result in causing these problems. So you've got this neuroendocrine tumor cell that's producing this 5-HT and other bioactive substances. It's supposed to be metabolized in the liver and not cause any problems. But when it bypasses that metabolism, then you end up with the 5-HT and other bioactive substances causing all of these problems, including the flushing, the diarrhea, the carcinoid heart, the mesenteric fibrosis, and all of the other symptoms that we've discussed. So how does right-sided heart failure work? Because again, in non-carcinoid patients, left-sided heart failure is what we see most commonly, but in carcinoid, it's right-sided heart failure because of the impact of those valves. So how does right-sided heart failure cause problems? Well, the right side is a venous return from the body organs, except the lungs. And so when you fail to have that return, that leads to venous congestion of body organs. So if you've got blood being backed up from the right side of the heart that's not being pumped through the right side of the heart, blood goes back into the liver. So you end up with hepatomegaly, which then can result in an increased jugular venous pressure and peripheral venous congestion. It backs up into the kidney. So you end up with kidney failure. It backs up into the peripheral extremities. So you get peripheral edema. You end up with ascites. So basically the body is telling you, we can't accept more blood because you're backing up and backing up and backing up. And so again, right-sided heart failure can cause multi-system organ complications. And so if you have a patient who's presenting with hepatomegaly or peripheral edema or ascites, and you're not sure why, and they have a history of neuroendocrine or carcinoid, start thinking, should I be looking for right-sided heart failure due to carcinoid heart? So for patients with carcinoid syndrome, again, the most important way to treat these patients and prevent progression to carcinoid heart disease is controlling the hormones. So decreasing hormone production and tumor growth. Medical therapy of carcinoid heart disease is really limited to symptom control and palliation. You can do valve surgery for carcinoid heart disease for symptomatic patients whose metastatic carcinoid syndrome is controlled. But if the carcinoid syndrome, if the hormone production is not controlled, you're going to end up with the same problem again. So you really need to focus on hormone control in order to treat carcinoid heart disease. So what are the tools that we have for hormone control? Well, octreotide from back in the 80s, as I talked about initially, it's approved in the US and Europe for these functional nets and for also acromegaly. Lanreotide came out in 2014. That is also another agent that we use. And then pasireotide is something that's approved in the US and Europe for Cushing's. We don't use it as often in this particular state. And then telotrestat has been approved recently, and it has actually been really helpful in controlling the hormone production and controlling diarrhea. So that's another agent that you can add on into your toolkit. I'm not going to talk about this too much because, again, tumor control is for those patients who have bulky disease, who have disease that you really need to control the amount, or the tumors themselves are causing problems. And so, again, those types of drugs like the biologics, chemotherapy, those are very important in those circumstances. For carcinoid heart disease specifically, you really need to be focusing on hormone control. So again, that goes back to the octreotides, lanreotides, and making sure you've got really good, strong control of the hormones so they're not causing these carcinoid plaques to build up in the heart valves. Somatostatin receptors are the perfect target for both diagnosis and for treatment, because as we know, somatostatin receptors can be targeted by both what we use, lutetium and dotatate scans, as well as the therapy. So that's something I think is really cool about carcinoid and neuroendocrine, that the somatostatin receptor can be utilized for both PRRT treatment and octreotide treatment, and also for diagnostic imaging like dotatate scans. Again, this is talking a little bit more about diagnostics. I'm not going to go into details, but we talk about octreotide scans and dotatate scans and ways that we can target these hormone producing agents by targeting those somatostatin receptors. And it's approved and it should be utilized widely for patients with neuroendocrine tumors. So PRRT, this is a newer agent that came out in the late 90s, and then late 2000s, Lutathera came out after the NETTER-1 phase 3 clinical trial showed the benefits. And again, this is really good in those hormone-producing types carcinoids if you're having trouble getting them under control with the octreotide and the injections. So a little bit of data on the NETTER-1 trial. It evaluated the efficacy and safety of lutetium dotatate plus these somatostatin agonists, looking for symptom control compared to octreotide alone and the longer acting agents alone in these inoperable somatostatin receptor positive mid-gut net tumors. And the NETTER trial, I think it was really transformative for how we were able to incorporate PRRT and these types of therapies into our practice. Just as a quick reminder, the NETTER trial looked at 4 administrations of the lutetium dotatate every 8 weeks, plus a somatostatin agonist versus octreotide alone every 4 weeks. And some of the key facts about PRRT. So PRRT uses targeted radiation to really kill the cancer cells from within. I love telling patients it's kind of like exploding things from inside. It's like sending in a sleeper agent to come in, target exactly the molecule that you're looking for, and attack those specific molecules. And so patients who really benefit are those who have positive targeted receptors. And many institutions offer PRRT now, and it's really a wonderful option for patients who are having progression of disease on just the somatostatin agonist alone. So again, this is a little bit more of a description of how the PRRT therapy works. Again, Lutathera binds to the somatostatin receptor type 2, the one that I said that's most likely expressed. Then the Lutathera is internalized in the cell, delivers radiation within the cell, and that induces some DNA strand breaks, which then causes tumor cell death. And what they found in this, looking at lutetium, the treatment, they found that there was an overall survival was 48 months in the PRT arm versus 36.3 months in the control arm. It was not statistically significant, but that is likely impacted by the high rate of crossover. These patients often live for a very long time because they don't have as aggressive of cancers. And but it did yield a statistically significant improvement in progression-free survival, as well as a meaningful trend towards improvement in median overall survival. So going back to how does all of this tie into carcinoid heart disease? Well, first you've got to establish that diagnosis on echo. Then you've got to control progression of the carcinoid syndrome with somatostatin analogs. If the patient has mild carcinoid heart disease, you can assess them with an echo every 6 months. If they have no symptoms or progression, just continue on that every 6 months. If they develop symptoms or if they have moderate to severe carcinoid heart disease, you need to make sure you're doing those echoes every 3 months, consult a cardiologist, and you need to make sure that you're assessing their primary neuroendocrine tumor disease status and evaluating the patient's performance. If you think the patient may benefit from a valve replacement or some type of surgical intervention, that is a conversation to be had in collaboration with their cardiologist. And it's really important, again, to remember, don't do surgery if you can't get the hormones under control, because all you're going to do is do the surgery and then end up with the same problem again when the carcinoid heart disease becomes a problem with the hormones being released. So in subjects who are refractory to somatostatin analog therapy, you can escalate the SSA administration. You can add on that telotrestat that I mentioned. You can initiate that PRRT therapy that I discussed. And in some cases, interferon alpha has been utilized. Everolimus and pasireotide are not typically recommended for this type of particular patient. Cape-Tem or temozolomide and capecitabine have been seen to be a benefit as a debulking option in patients who have well-differentiated small bowel nets with a higher Ki67 index. But again, for carcinoid syndrome and carcinoid heart, you really need to be making sure that the hormones are under control, because that's where the damage is coming from to the heart. So looking at the dosing, you've got to think about hormone control and tumor control. For looking at hormone control, you start with a short-acting SSA and overlap it with a long-acting if you have a really severe patient with severe carcinoid syndromes. You can titrate the dose and frequency as needed per patient. For tumor control, so if you're not worried about hormones as much, so you're not dealing with carcinoid syndrome, you're more worried about tumor control, you don't necessarily need to overlap with short-acting unless you have a functional tumor. There isn't a lot of data to support the routine use of above standard dosing of SSAs for tumor control as compared to hormone control. And so again, I'm just going to say that there's a difference between controlling tumor growth and controlling hormones. So this is a kind of overview of how you can control tumor growth, looking at surgery, chemotherapy, and incorporating in different hormonal agents as well. And the most important thing, regardless, is you need to be having a multidisciplinary approach. I think that's the most important component to all of this. When it comes to carcinoid heart, when it comes to neuroendocrine tumors, when it comes to carcinoid syndrome, you need to be incorporating in the important consultants and multidisciplinary team. So I really like to get the cardiologists involved. Sometimes surgery gets involved. Sometimes you need interventional radiology or endocrinology. Think really critically about who can best help your patient in a multidisciplinary approach. So, and this kind of goes to that cardiology, medical oncology care coordination. Usually the way I kind of think of it is managing symptoms of hormone excess. That's really the oncologist's job. We need to be focusing on how can we make sure we're controlling their hypotension or hypertension? How can we make sure we're controlling the amount of hormone that's being released? The cardiologist needs to help with the cardiac symptoms that are happening. And it really is a dance that you do in concert, trying to figure out how to address the symptoms as well as the cause of the symptoms. So a question that I get asked is there a role for telotrestat in carcinoid heart disease? And the answer is we don't know yet. There was a phase 3 trial, Telestar, looking at 2 patients with carcinoid disease who are in this trial. One demonstrated a recurrent of carcinoid valve disease on the tricuspid and pulmonic tissues. one patient demonstrated carcinoid valve disease on the native valves, suggesting that the likelihood of a valve surgery might be imminent. I think that there's more to come in this space. I think we'll see more as we see more patients getting these drugs to see if there really is a benefit for patients with carcinoid heart disease. This other trial that it's a randomized phase 3 trial looking at telotrestat plus SSA versus placebo versus SSA. They're looking at the percentage change in the BNP. And so I think this is going to be another interesting trial, and I'll be waiting to see the data from that. So with that, I'm going to end here and say thank you so much for bearing with me with my technical difficulties on some of those slides. I hope this was educational and of interest, and I hope you learned a little bit about carcinoid heart disease on this talk. Thank you so much.
Thank you so much, Dr. Jain. That was great as always. I want to thank you again for doing this show again. It's really great to have people come back and share this vital information with everybody. Once again, everyone, thank you so much for joining us. Don't forget, for all information on upcoming events and even other content, even you can check out Dr. Jain's last podcast that she did over at the NCAN YouTube, over at any streaming platform, and also at netcancerawareness.org. And we will see you next time on Let's Get Real.